Good afternoon, everyone. On behalf of TaskMed, I would like to welcome you all to Medcast, Insights into Healthcare, a learning initiative by TaskMed. Today, it's a great pleasure to have with us Dr. Singla, who is a consultant endocrinologist and director at MKS Endoconsult, Ludhiana, Punjab. We welcome you, sir. Sir, we look forward to hear from you on today's topic of discussion, Insights into Diabetic Dermopathy. Over to you, Dr. Singla.
Okay, just a minute. Are slides full screen?
Yes, sir. Kindly do it. Full screen, sir.
Okay, just a minute.
It's visible. So from the above also there is a view wala. Click on to view and then it will be full
Just a
screen.
minute. Actually, below it is not. Just a second.
Yes, sir.
Yeah. And how to do it from there?
So fit to window. We can
Okay.
try it out because there is some other settings at your laptop. Fit
Yeah, its setting has changed somehow. Fit to
to,
window.
yes, sir.
Now
So
I
we
have
can
done.
do one. We can do one thing. You just unshare it and then reshare, sir. Might be the setting will come
Okay,
again.
just okay. You do it then.
From my end, I feel it will be difficult. Stop it.
Okay, just tell me fit to window. Fit
So
to window.
just unshare it.
Okay.
Again, share
Okay.
it.
Just a minute. Now is it full screen?
Yes, sir. It's perfect, sir.
Okay. Good afternoon, everyone. So today we are going to discuss dermatological manifestation in diabetes. So if we see the incidence of dermatological manifestation in diabetes, it is to the tune of 30 to 70%. So it's very, very common. And day in and day out, we see a lot of patients with diabetes who come to us with the skin complications. And many times we see patients developing these skin lesions before the development of diabetes. And in fact, sometimes we are able to diagnose patient when they come to us with melanoposthitis, vulvovaginitis, boils or carbuncles or any other itching in the skin. So this is how they present sometimes first to the skin specialist and then they come to us. So meaning thereby skin manifestation of diabetes are very, very common. And the prevalence of these complications, skin complications is very common in type 1 and type 2 diabetes. And cutaneous infections are more common in type 2 diabetes. And in type 1 diabetes, autoimmune related lesions like vitiligo are very common. And good metabolic control, it helps in preventing and sometimes curing these diseases. So blood glucose control is very, very important to treat the complications of dermatological manifestations in diabetes. So now we will discuss the broad classification of skin lesions. So first of all, there are skin lesions which are strongly associated with diabetes, and then skin lesions of infectious etiology, and the lesions secondary to complications of diabetes, and lesions related to the treatment of diabetes. So the common and rare skin disorders in diabetes are diabetic dermopathy. It's very common. Necrobiosis lipoidica. It's not that common. Diabetic bulle. Acanthosis nigricans is very common in type 2 diabetes. Scleroderma not so rare. Vitiligo, it happens mostly in type 1 and also in type 2 it can happen. Then disseminated granuloma annulare. Then generalized pruritus is very common in diabetics. Then lichen planus, diabetic patients are more prone to this lichen planus. Then diabetic thick yellow skin, eruptive xanthomas due to cholesterol, and then diabetic rubeosis. All these complications can happen in diabetes. So this picture you are seeing is of diabetic dermopathy on the shin of both the legs. You can see these dark typical diabetic dermopathy lesions. So these very commonly, if you see the legs of the patient, so you will see these lesions. Then necrobiosis lipoidica. Here you can see this necrobiosis lipoidica on the shin. This is the yellow spot and this is the reddish spot in the skin. Then lichen planus, these are purple pruritic lesions which are papule type, 5 P's of lichen planus. Diabetic bulle, which lead to cellulitis and thereby leading to further gangrene also. So it is very important to treat diabetic bulle. Then acanthosis nigricans, the blackish pigmentation on the nape of the neck you can see here. This is the sign of insulin resistance. And even in PCOD also you will see such lesions of acanthosis nigricans. Eruptive xanthomas, these are due to dyslipidemia, and these are we have seen these lesions also in diabetic patients. Diabetic rubeosis, I people see these lesions most of the times. And among all other cutaneous complications of diabetes, diabetic dermopathy is the most ignored complication, which affects 33% of the diabetic population, because this is silent, does not cause much of discomfort. So it is ignored many times. So these, what is diabetic dermopathy? There are shin spots which are multiple above the surface of the skin. So most of the times these are on the shins, but on the thighs and forearms also these lesions can be found. And these are hyperpigmented lesions, and there is atrophy of the skin also. It is twice common in the older men, and patient should have more than 4 lesions to diagnose diabetic dermopathy. And this diabetic dermopathy is a marker of microvascular disease, and it is having a high correlation with diabetic retinopathy. So if you find these lesions on the shin of the legs, so you should always do the fundus testing, because there is a high chance of diabetic retinopathy in such patients. And diabetic dermopathy is the constellation of well-demarcated macules or sometimes papules located on the anterior surface of the lower legs, and it is usually found in patients with diabetes, and it is the most common cutaneous marker of diabetes. And diabetic dermopathy is found in 12.5 to 40% of patients, and most often it is found in the elderly, and especially clinically also we see these lesions mostly in the elderly population only. So, in one of the case series of 100 consecutive inpatients or outpatients in India with diabetes and skin lesions, diabetic dermopathy was found in 36%. So, but the incidence was much lower in a second case series of 500 patients attending a diabetes clinic in India, with only 0.2% were diagnosed with diabetic dermopathy. So in this paper, authors concluded that because majority of patients were well controlled, that is fasting sugar less than 130 in 60% of the patients, so cutaneous signs of chronic hyperglycemia were decreased. So the prevalence of diabetic dermopathy varies from uh, person to person, because uh, many patients are controlled, and many populations diabetes is not so well controlled. So incidence or prevalence may vary in the different populations. So it is to the tune of around 30 to 70%. And diabetic dermopathy lesions can sometimes may be seen in patients without diabetes, especially patients who are having circulatory compromise. In that population also, you can see such lesions. Is especially and those histological sections demonstrate. In one study, patients with type 1 diabetes and diabetic dermopathy had marked reduction in the skin blood flow at normal appearing skin areas on the pretibial surface of control and non-diabetic control patients. So possibly these lesions are vascular because uh, there was a reduction in skin blood flow which was found in one of the studies. And there is an association between diabetic dermopathy and presence of retinopathy, nephropathy, and neuropathy. And in fact, in one of the Turkish study, women with diabetic dermopathy appear to have a more severe sensory neuropathy, that is, loss of deep tendon reflexes, superficial sensory loss, and loss of vibration sense, as compared to patients without these skin lesions. And a high prevalence of carpal tunnel syndrome, that is 63.8%, was found in these patients in this study of Turkish women. So appearance of diabetic dermopathy can vary from person to person, and characteristically you will find reddish brown round. It is typically asymptomatic, meaning that it usually doesn't present with any symptoms. Patient, when it sees the lead, then only they can recognize these lesions. And these lesions are primarily on the shins, but they can be found on other parts of the body as well. But they are less likely to develop on those areas, that is thigh, trunk, or arms. The most common site unpleasant to look at to the patient. Aesthetically, they don't look so good. And diabetic dermopathy does not usually cause symptoms like burning or stinging sensation. And the patients one lesion or cluster on the shin and other parts of the body. And when spots develop on the body, mostly they are formed bilaterally. And these lesions or patches don't break open or release fluids, and they are also not contagious. The only thing is they look unpleasant. Otherwise, most of the time, you can diagnose these lesions. So now coming to the treatment of diabetic dermopathy. So tragedy is that till date we don't have anything that offers a helping hand to patients with diabetic dermopathy. So for these patients, they end up most of the times we end up sending the patient with a advice like apply coconut oil, Vaseline, or other cold cream products. So most of the times we say to the patient that with time they will go. So this is the common advice which we give to our patients. On the other hand, if you wonder that what a dermatologist is prescribing or advising them, majority of them believe that there is no specific treatment available and tend to advise them either apply a makeup to cover the spots, or if dermopathy produces dry scaly patches, you use a moisturizer or oils containing aloe vera, glycerin, or light liquid paraffin. So that is the most commonly advice given by the dermatologists. So, but the drawback with moisturizers or oils is that they only work on the loss of moisture or dry skin, but they lack other properties like healing of the skin spots, antimicrobial, antioxidant properties. And drawback with these moisturizers or oils is that they contain paraben, which means it is not suitable for every skin. It has a high tendency to cause any degree of skin irritation or inflammation because diabetic patient skin is already very thin or very sensitive. If a paraben containing topical item is applied, then chances of getting skin irritation or inflammation doubles. So rather than helping the patient, we are harming the patient in some form because paraben can cause skin irritation or inflammation. So if that is not the good option, then what should be the treatment criteria? So there should be some topical agents that should hydrate skin and protect trans epidermal water loss. So reduce shin signs, inflammation, or fasten up re-epitheliation process by increasing blood flow to the area and helping to create the collagen fibers. So mainly it is the hydration, and we should reduce the inflammation and we should increase the blood flow and thereby helping to create the collagen fibers. But along with this, if we get a benefit of antibacterial, antifungal, antiviral, anti-inflammatory, antioxidant, and paraben-free substance, then it will be a win-win situation for our patients. So if we get all these properties together, which hydrates the skin, creates skin barrier, prevents itch intensity, facilitates healing, prevents microbial infection, probably we will be able to manage the diabetic dermopathy. So nowadays, creams are available. So which can help patient can apply on these lesions, and it helps in the healing of these skin lesions, and also reduces the color of these skin lesions, and aesthetically patient looks better. Thank you all for your patient listening.
Now I would like to request all my participants, if they have any query, kindly write down onto the chat box. Thank you, Dr. Vikas. So we have one question, doctor. So we have
I
two
think there
questions.
are, yeah.
There are two questions currently onto the chat box, sir.
So I will answer just a minute. So there is a question from Dr. Ranjan Sood. I have a patient with which developed hypermelanosis scars on his neck. So probably it will be acanthosis nigricans. So acanthosis nigricans is one of the markers of insulin resistance, and patients who have obesity, they will develop acanthosis nigricans. So these lesions can be reduced by reducing the weight, and sometimes skin people give them local applications of benzoic acid or something like that. So with that, these lesions can be reduced in intensity. But main thing is patient has to lose weight for reducing these acanthosis nigricans. Special soap. So, sir, for skin lesions, like for in diabetic patient, we tell them to apply some soaps which contain a lot of moisture, like in popularly like Dove or like that pink color. So that those soaps contain little bit more of moisture and they do not dry the skin. So we prescribe that, but other soaps like dermatologists, they have some like some pharma companies, they are making soaps which contain moisturizer, so patient can apply that also. So there is a question from Dr. Karamveer Goyal. What is the success rate of recombinant DNA growth factor creams in diabetic foot ulcers? So, sir, that's a very good question. So, actually, these DNA growth factors, recombinant DNA growth factors, which we are using in patients whose wound is clean, means they if they do not have any infection, then only we give this recombinant DNA factor. So they help, like they help in fastening the healing of diabetic foot ulcers. But when infection is controlled, then only we should apply these recombinant DNA growth factors. Otherwise, in bad or like infected wounds, we should not apply these recombinant DNA growth factors. So there is another question. Is there any role of antibiotics? So antibiotics do not have any role in diabetic dermopathy because these lesions are non-infected. So only these creams, which like from Tasmet company, Diaglit soft cream, which has come up new. So we have used it in a lot of patients, and in fact, we have found good results of this cream, like in dryness of the foot also, diabetic dermopathy also. So results are good. Means patients are also satisfied with this cream because it helps in the reducing the intensity of the color as well. So there is a question from Dr. K. Singla from Dhuri. So there is a diabetic patient who has black scar mark on both lower legs. So what to do? So like possibly these black scars will be diabetic dermopathy only, because if it's a necrobiosis lipoidica diabeticorum, so that is brownish and yellowish in color. So you have to differentiate it from that. So you can apply this cream in this patient for long time, and possibly these scars should go with this cream. So there is a one more question from Dr. Rakesh Verma. Any relation of food which can trigger dermopathy like spices, or the food which aggravates eczema like dairy, nuts, eggs, etc. So diabetic dermopathy lesions, these etiology is in the circulatory system and neuropathy lesions. So these lesions are not exaggerated with the foods like dairy, nuts or eggs. So it does not have any relation with the food. So there is another question from Dr. Charanjit Garg, who is skin specialist from Barnala. So, what is the important in assessing skin lesions, whether current level of glucose or 3-month control? So, we have to have a very good glycemic control. We have to control both the fasting and postprandial glucose control and 3-month control, that is HbA1c also, because HbA1c is the ultimately we have to control it. Then only patient will have control of all the infections or microvascular or macrovascular complications. So nowadays we do even CGMS or ambulatory glucose profile of the patients to see whether there are fluctuations or not, because sometimes only fasting glucose is not enough. Sometimes fasting is control, but postprandial is not control. So many patients do not check their postprandial or HbA1c. So it is very, very important to get all the three things under control. Is there any other question?
No, sir, because in Q&A also, the same question was asked by Dr. Dheer. He has written into chat box also. So I feel we have covered all the questions of our doctor. Sir, we have one more. Just received one from Dr. Rakesh Singla.
Okay, just a minute. In the chat box, okay.
Yes, sir, in the chat box only.
So which cream should we use? Till now means we did not have much of the creams available with us. From Tasmet company, they have this Daglit soft cream. So patient can apply that. So and for long time, 1 to 3 months like that, patient should apply it, and we have seen the results also. The results are good.
So I hope we have taken all the questions of our doctor. With this, I would like to request all my doctors, whomsoever want the samples of Diglid soft, they can. I'm just pinning up my mail ID. My name is Neha, and I'm a product manager at Tasmet. I'm just putting my mail ID here. Just give me a mail. I will provide you with the samples, and would like to request all the doctors to kindly try it on to some of the patients, and we are damn sure that your patient will gain the benefit of it. My mail ID is pmt@tasmedlab.com. I have written it into the chat box also, sir. And my colleagues will also going to meet you all into your chambers also to discuss about this particular product. The beauty of this product is this, that none other company is having. This is a full package for you. It is not only going to moisturize the skin condition of your patient, but along with this, it is also going to heal those skin spots which is coming up into it. And our cream is also having the benefit of antimicrobial, antibacterial properties. So it is completely a win-win situation for your patient. And with this, I just want to ask Dr. Singla, if he permits me, so can I close down the session, sir?
Sure, sure, sure. Yeah.
So
Sure.
yeah, thank you, Dr. Singla, for joining with us today. It was really an insightful discussion for us as well as for our listeners. I would also like to thank all the doctors for being with us and for their active participation during the session. Thank you, everyone, and have a good day. Thank you,
Thank you.
Dr. Singla.
Thank you. Thank you.
It
Thank
was
you,
really a
everyone.
nice discussion, sir. Thank you
Thank
so
you.
much for joining with
Thank
us.
you. Thank you.